All right, so my name is Marina Hopes. I am a glaucoma and cataract surgeon in Springfield and Broomfield hospitals. I'm a clinical lead in Broomfield Hospital as well. I was asked to talk about glaucoma to help to understand this problem. And we're going to cover quite a lot. Again, I think the plan is to have a discussion at the end. Originally, we wanted Mr. Andrea to have present his talk first, but we will be flexible and see what we will end up doing. So I will talk about definition of glaucoma and mention a few important facts about glaucoma, risk factors, and I will talk about in more details about structure of the eye to understand why we have different type of glaucoma. I mentioned about ocular hypertension, treatment, side effects of the treatment, and what patients actually do themselves to help to manage their disease and prevent it, and a few useful links for you to look for more information. So glaucoma is a disease of the optic nerve, which positioned at the back of the eye, and it transmits the signal from the retina to the brain. Typically, it's progressing very slowly, and peripheral vision is affected on the first stage, but central vision can be affected and it can progress rather quickly. Because the majority of the patients are not aware of their peripheral vision problems, they tend to present late, and they can lose quite a lot of sight before they will be told that they have glaucoma. And where is this important facts coming to? Because we expected about 50% or 44% exactly, double the number of patients to see with glaucoma by 2035. About 2% of our population over 40 would have glaucoma, and it's about 500,000 of people in the United Kingdom. And 10% of patients who are getting blindness are actually developing it from glaucoma. It's very common we see surprise on our patients' faces where we're telling them that they have glaucoma because they don't have any problems. There are no symptoms, and a lot of patients don't know that they have a disease. And if you have loss of vision from glaucoma, you can't recover it. So early detection and treatment are paramount, and you're not alone. There is a lot of help available to help you to seek specialist help to be tested for glaucoma. And even if you don't have it, it's still worthwhile to be checked by a optician to make sure that your pressure and your basic function of your vision are up to date, because age is one of the biggest risk factors for glaucoma development. So after age of 40, it's worthwhile, especially if you have family history of glaucoma. So glaucoma can develop in anyone, but this particular group of patients which are described in this slide are at high risk for development of glaucoma. So Afro-Caribbeans, we see a lot, people with higher pressure or extreme prescription with glasses, nearsighted or farsighted, who had previous history of trauma or inflammation in the eye, and a general poor health, people who have poor blood supply to the optic nerve, people with diabetes, high blood pressure, general circulation problem like people with migraines, they can develop glaucoma, predisposed to have it at an early, as they're getting older. So for us to understand glaucoma, I will explain the anatomy of the eye. So the eye is a confined space, and it's divided in two parts. It's the front of the eye and the back of the eye. In the front of the eye, we have a lens, and we have iris, which sort of sits in front of the lens. And before the iris, we have a cornea, transparent part of the eye. At the back, we have a retina and optic nerve. An optic nerve is like a cable. It's full of microfibers which are linking eye to the brain. So the light goes through the pupil to the back of the eyes, an electric signal which transmits by the cells in the retina to the optic along the optic nerve to the brain. So this balance of pressure inside of the eye, it's controlled by fluid. And we're constantly producing fluid in front of the eye, which is draining through the small space which positioned between iris and the cornea called drainage angle, through small drain called trabecular meshwork. And it's maintained reasonably constant eye pressure, and it can vary between 8 and 24. It's all can be within normal range. In glaucoma, there is a blockage or the clogging of the drainage system. So the fluid is made up, but it has nowhere to go, and the pressure goes up. And the nerves cables at the back of the eye compressed by the pressure, and they are getting lost. So the parts of vision developing patches of vision loss is linked to the number of cables or microwires loss inside of the optic nerve. And when they're completely gone, it's when patients develop blindness. So ocular hypertension, it's not glaucoma. Patients have high pressure, but their optic nerve function and structure are actually normal. And we know that about 10% of patients with ocular hypertension can progress to glaucoma within 5 years. There was a big study published in more than 20 years ago now, and it's still the best data we have up to date. If patient is on treatment, we can halve the development of glaucoma as long as the pressure is controlled. So glaucoma typically divided in two major parts, open angle and closed angle. So open angle is where there is a blockage inside of the drainage system. You can't see it, but there is a blockage somewhere on the way of drainage. Fluid can get to it, but it's not draining somewhere behind the eye. And there is a closed angle where the fluid can access the drainage angle, because it's like a piece of paper put over the drainage where iris or large lens blocking the access of the fluid to the drain. So open angle glaucoma is divided by high pressure and normal pressure. When high pressure develops, it's very easy to pick up. You go into optician, and optician tells you that your pressure is high, it's a risk for glaucoma, you need to be checked. But in normal tension glaucoma, pressure still can be within normal range, but the eye is becoming too sensitive to this pressure. And the patient losing the part of the nerve despite pressure normal for average person, but for them it's too high. In close angle, it's typically a painful condition. It usually presents with an acute attack, as open angle tend to be asymptomatic. There is no pain. So it's the biggest difference between pressure difference and that is gradually develops, and patient is asymptomatic. In closed angle, they tend to present very high pressure in 60s, with pain, sudden loss of sight, headache, nausea, vomiting, halos around the light. And it's typical emergency for the eye. Pressure needs to go down as quickly as possible. So we'll call it true emergency. Angle can be closed for some time, and it's still sort of allow a little bit of access of the fluid to the eye. So pressure might grow up gradually, and then we call it chronic angle closure, which is not very common, but we do see it. So when you come to eye specialists, we will do your vision on a Snellen chat. We will check your ability to see. We will check eye pressure with Goldman tonometer. You'd have it on every examination with an eye doctor. We will check the condition of your drainage angle with gonioscopy. It's where we put in a special lens on your eye to stop it from your eye from closing. And we do visual fields as a function of the nerve, and optical coherence tomography. We're checking this, the structure of the nerve. It's a big topic, and I think it will be useful to have this conversation on its own, just about the test we do for glaucoma. But just to summarize for you and give you overview about what is needed to be done in glaucoma, it's very important to know that it's a teamwork. Doctor can only tell you what to do, but you are the person who's putting the drops. And if you have questions or you have a problem, you have to tell us, because things can be changed, adjusted. Every treatment has side effects, and it's very important to communicate your problems, because things can change. We can use drops, we can introduce the laser, we can do laser instead of the drops if drops are causing side effects, and we can do surgery. We tend to deal with surgery later on because of potential more serious side effects, but sometimes laser or drops are not working, and we tend to offer it earlier. So if we talk about eye drops, there are 4 major groups, and we tend to use them on its own or in a combination. Some drops reducing the amount of fluid produced in the eye, and other drops, they improving the drainage of fluid from the eye. And there are 4 major groups. So the most common side effects, and I try to make it more general because more or less they all have similar side effects. They can cause itchiness and discomfort in the eye, redness, problems with breathing, problems with pulse, dry mouth, blurriness of vision or dry eyes, eyelashes, growth and pigmentation of the skin. We do laser, and we do laser a lot, and the laser can be divided in 2 major groups. The laser which improves the drainage, so it tries to unblock or unclog the drainage pipe, or it's reducing the amount of fluid build up in the eye produced. And the most common laser is selective laser trabeculoplasty. Sometimes we even, it's actually proven that SLT can be the first line of treatment. And we will try to get it since Springfield Hospital, this laser, to help our patients. It's done for open angle glaucoma. As for close angle glaucoma, we do laser iridotomy, and we have this laser in Springfield. And we're making a small opening in the pigmented part of the eye to extra drain the fluid from the front to the back to reduce the acute attack of eye pressure. Micropulse laser and diode laser is applied to the structures which are producing the fluid, the aqueous humor, and it's applied to the periphery of the cornea, limbal area, and it's tend to be done in later stage of glaucoma. So surgery, again, I expected Mr. Andrea to talk earlier about surgery in glaucoma, like cataract with angle improving drainage procedures. We call them MIGS. MIGS stands for microinvasive glaucoma surgery. We can do it in combination with cataract, try to get more fluid accessing the drainage angle, or you can do them on their own. The most common procedure is called trabeculectomy. It's nearly 50 years on the market. And newer procedure called peripheral stent or tube surgery. It's where we insert in quite a noticeable size tube to drain the fluid outside of the eye. I will talk about it in brief in a second. So the 4 major mixed procedures we do. We do iStent, Hydrus, Omni, and Minijet. So what they mean? You accessing more fluid drainage to the back of the eye, and you can put like a small stent. It's called eye stent, but it's a very small, and you have to put minimum 2. And the logic is that if you put in a stent and you have to leave something in the eye, you better put something bigger, which dilates like a stent which people have in the heart, to dilate and allow more access of the fluid to the back of the eye. So a majority of people at the moment having their hydrus inserting after cataract surgery to help the drainage of the fluid. We also do Omni procedure because it's one of the new procedures, but you don't leave anything in the eye, but you're opening the drainage channel. So instead of putting a stent, you just open it. And the most new procedure which we do, but we do it in Broomfield, we put in like a small sponge in the drainage angle, and then it absorbs the fluid and allows it to drain to the back of the eye. So that all these procedures are designed for particular problem, and we tailor it to the patient. About trabeculectomy, we're creating effectively a pocket of fluid draining from the back of the eye. So you can see this iris, and the fluid goes through the wall of the eye in between layers of the conjunctiva. We have a lot of data. The surgery works and works very well, but there is a lifelong risk of infection and scarring, apart from many other issues we can have in a short period after the surgery in later in life. Razor-flow stent, I just showed you the difference. It's a small stent which we insert between layers of the conjunctiva. It's very small. It's smaller than 0.5 millimeter in diameter, and it's about 8 millimeters in length. It's a much faster recovery than trabeculectomy and much more comfortable than tube procedure. Because the tube itself, just for you to understand, it's a lot bigger, and it can interfere with the eye movements after the surgery, but it controls pressure very nicely. So we do a lot this procedures a lot, but again, we choose each surgery for the right patients based on what will be the best for them at this particular stage, because we work for you, and we design things with the least interruption to your life, with the least side effects, and potentially prolong your ability to see and function, like driving. And what you can do is try to limit how much coffee you drink. So it's shown that more than 5 large cups of coffee per day, it's actually can increase your eye pressure. Meditation is proven to be useful at reducing the level of cortisol in our blood and reduce eye pressure spikes. Good sleep can generally help your well-being, and again, it helps with the level of cortisol. Limit alcohol, but in a small amount, it actually can lower your eye pressure. Smoking is no in any problems with health, and if you can try to stop smoking, it will be really good for your general health and for health of your blood vessels. It's important to note that flying is not a problem, and there is no evidence that flying can cause any problems with glaucoma. I wanted to mention ginkgo biloba because it's the only, I'm asked many times, can they improve some diet which can slow down glaucoma or help the treatment? The only herb which was well studied and publicized is ginkgo biloba, and it can slow down clotting, and it will improve the blood supply to the optic nerve, but you have to be very cautious with it because it can interfere with medication and it can actually cause bleeds. So if you start it, you have to be very cautious and tell your GP that you're taking it. So I wanted to mention for you Glaucoma UK. It's a really useful site for additional information and generally answer all your questions. And if you have glaucoma, it helps you to find people with the same problems, and sometimes it can be very useful to have a chat to somebody who has the same problem. I like Royal Institution for Blind website. It gives you really a good overlook of information. And NHS gives you some background information about glaucoma. Thank you very much.
So everyone says, what is a cataract? And there's a lot of misconceptions about what a cataract actually is. If you go to the next slide, if you go, it's actually a cloudiness of the lens inside the eye. It's not actually a covering over the surface of the eye. There's a lot of misnomer about what a cataract actually is. It's something that grows on the front of the eye. It's not. It's a lens which is actually inside your eye, your natural lens, which has gone cloudy, of which the commonest reason is increasing age, but of course there are other reasons. Next slide. The commonest, so if you go back one, it's still important cause of visual disability throughout the world. It's the commonest visual disability in the Western world, and it's very, very common. And in fact, the last numbers that were picked up by the Royal College suggest that up to 30% of UK individuals will have some degree of difficulty due to cataract over the age of 65, and that actually increases with age. So by the time you're 80 to 84, 60% of the population have some degree of cataract, and 71% if you're older than 85. So it's something that's going to definitely impact on you as you get older in life. Next slide. So this is probably an example, schematic as to what a cataract looks like. You can see a normal eye on the left. The light can go into the eye and be refracted on the intercept and on the surface of the lens, and the light sort of focuses at the back of the eye. But with a cataract, you can see that you have all these sorts of rays of light that have been thrown off into different directions, and that's what a cataract actually does, and that's why things become significantly blurry. Next slide. So what sort of effects does cataract cause? Well, it causes a gradual reduction in the quality of vision over time, but the type of things that patients often report are things like glare and halos, particularly while night driving, and difficulty reading and watching television. They suddenly find it's more difficult to see the subtitles, for example, and reading becomes more of a challenge. And certainly if you enjoy sport like golf and bowls, you might find that becomes more difficult to see the golf ball as you hit it out in the distance. But also there can be a lack of contrast and colours. It's very rare for cataract to cause a sudden loss of vision or an inability to work, but occasionally we find people present more acutely, having had a cataract for a while, but it suddenly got that little bit worse, and it's called them a sudden loss of vision. Next slide, please. So these are some pictures showing what you might actually see if you had a cataract. So normal vision on the left. In the center, you can see the vision starts to get a bit more blurry as the cataract is beginning to develop, and as it becomes more advanced, things become distinctly out of focus and obscured. Next slide. So what are the risk factors of developing cataract? Well, I mentioned the most obvious one, which is increasing age, and there's lots of theories as to why people develop cataract. It's believed that UV absorption changes the metabolism of the lens, and that can sometimes cause proteins to be deposited within the lens itself and cause some degree of cataract through protein aggregation. But also there are other important causes, and certainly nutrition and poor diet, particularly in the third world, is a common cause of cataract at a much younger age. Lifestyle, in particular smoking and heavy alcohol consumption, can also lead to development of cataract. Dehydration is a very important cause, particularly in the developing world, and we see people have cataracts at a much younger age group in the third world. But of course, we mustn't forget about some medical disorders, and certainly conditions such as diabetes can also cause cataract to occur in a much younger age group. There are also eye causes or ocular causes. Things which cause inflammation and trauma are predisposed to causing cataract. And you can also develop cataract through genetic influences, and some people have cataract at a young age due to congenital reasons. Next slide. So what is the treatment of cataracts? Well, there aren't any magic drugs that can reverse cataract. Whatever people say, there has been no proven benefit of any drugs or eye drops for the treatment of cataracts. Although people have said that this might reduce your chance of developing cataract, there's been no randomized controlled study or body of evidence which says that there's any particular drugs or eye drops that can prevent you from developing cataract, which has gone through randomized controlled clinical trials. Spectacles can help initially, and that's because as the cataracts develop, it can change the focusing of the eye. It can cause you to become more short-sighted or paradoxically more long-sighted in certain types of cataract. And this might help you initially if you're interested in reading, for example, but eventually spectacles can help initially, but eventually they fail. And so the optician tends to refer the patients for cataract surgery. And if there's no action taken, there's a gradual worsening over time, but fortunately there's very effective surgical intervention. Next slide, please. So a question that I always ask is, who should have cataract surgery? And the decision to proceed to cataract surgery should really depend upon whether cataract is actually interfering with the patient's quality of life, and in particular stopping them from doing essential functions like working or driving. Now, at the moment, the NHS is quite mean. It's got various visual criteria for making sure that you need to have before you develop cataract. And that's normally a level of 6/12 or worse. And that's because that's considered the driving vision standard. And so opticians are encouraged not to refer patients to hospital eye services on the NHS unless their cataracts tend to be worse than 6/12, even though theoretically, you know, someone with a much lower degree of cataract can be capacitated but can still see better than the 6/12 chart. Certainly this doesn't apply in private cataract surgery, because we would happily do anyone's cataract if it's causing them any degree of visual disability. Next patient. Next slide, please. So what is the scope of problem with cataracts? Well, these are the most recent figures provided by our Royal College, who looked at cataract surgery performed in the NHS. And back in 2019, pre-pandemic, at least 440,000 procedures were done in the NHS alone, and this is not including private practice. And the outcome of cataract surgery is very successful. It's probably the most successful operation and intervention out of all procedures in the NHS. You get a very good improvement in visual function. It's considered to be an operation with very low morbidity and mortality, and it's beautifully delivered as day case surgery. And with an ever-increasing population, you know, the NHS units up and down the country are challenged to provide increasing numbers and surgical interventions. But the problem is the resources haven't quite matched the increasing number requiring surgery. And that's why the NHS waiting lists have gone up and up. And more cataract surgery is now done in the private sector. Next slide. So what else has been proven to be beneficial with regards to cataract surgery? It significantly improves the quality of life, and there have been many studies that have shown this. It allows the continuation of driving and maintenance of independence, which is very important to people as they get older. And there's also some evidence that it reduces your chance of developing dementia, and importantly, reduces the chances of falling if you become elderly, if you have cataract surgery at an earlier stage. So it's quite an important intervention, and we shouldn't just think of it as just something that we just do as we get older. If it's impacting on your quality of life, you should have it done at a sooner stage. How is cataract surgery actually done? We use an energy called phacoemulsification. Now, phacoemulsification or ultrasound is a technology that's been around for quite a long time. Next slide. It uses a high frequency vibrating ultrasound needle, which generates heats in the eye, but at the same time, the probe actually irrigates and cools the breakdown of the cataract fragments, and we aspirate them. So we're able to deliver cataract surgery through small micro incisions, often less than 2 millimeters wide. And when this first came out in the sort of late 70s and early 80s, it was very revolutionary, because prior to that we all had to make very large incisions in the eye, and it literally squeezed cataracts out and do lots of stitching. And when this technology came, it allowed us to do things through tiny small incisions, which led to a shorter rehabilitation time and much better, quicker outcomes for the patient. Next slide. Modern phacoemulsification surgery allows the surgery to be done using eye drops only, or known as topical anesthesia, but also small incision cataract surgery. Often the surgery is sutureless, so no stitches are needed. The shorter rehabilitation times, for example, most patients have good vision the first day post-operatively and maintain very, very good visual outcomes. It's day case surgery, and most of the time only one follow-up visit. And in modern cataract practices, this is often provided by the referring optometrist in the NHS or by the surgeon if it's in the private sector. Next case. The outcomes have been shown to be fantastic. So over 95% of people get an improvement at the level of vision of 6/12 or better. In most of the time, if there are no other eye problems in the eye. And 90% get a very good outcome if they have other comorbidities. There are very, very high satisfaction rates with regards to cataract surgery, over 95%. And there are lots of audits that have been provided by the Royal College of Ophthalmology, and it's still maintaining an active audit. But there's always the need to maintain high quality, and there are lots of guidelines constantly being published as to how we need to run cataract services in order to ensure high quality. Next slide. Now I'm going to move on to lenses, because there's been a great movement into offering patients much more lenses. Now the first thing to say is if you're an NHS patient, you will only be offered a monofocal lens. Now what is a monofocal lens? It's a lens that gives you a clear focal point, often in the distance. But if you want to see at a different distance, for example, intermediate or near for reading, you would need to wear glasses. There's also another lens called a toric lens, which corrects astigmatism. Now, what is astigmatism? Now, that's when the shape and contour of the eye is more conical and a bit shaped like a rugby ball, and that throws the rays of light and makes them seem a bit more blurry. So you can have a monofocal toric lens that can correct your astigmatism as well, so you can have better unaided vision in the distance. And there are multifocal lenses now available on the market, which allow patients to have either extended depth of focus and can give people reading vision as well as intermediate vision, in addition to distance vision. And this allows patients to have, if you like, be glasses independent. We'll talk about these in a bit more detail now. Next slide. So I've got here a schematic showing three types of lenses. The first one is a monofocal. The middle one is a extended depth of focus lens, and the third one is a trifocal. So you may hear about different types of lenses that can be implanted. So the one on the left will only give you very good distance vision, but works less well for intermediate, and often the patient requires glasses for intermediate and near, whereas the extensive depth of focus lens has good distance and intermediate vision, is good for the outdoor types, but won't give you good near vision, and you'd need reading glasses for close work. Whereas a trifocal has three distinct focal points at both distance, intermediate and near, and will allow the patient to have slightly better seamless vision and hopefully more spectacle independence. Next slide. So the monofocal tends to be implanted to give people good far vision, and it's the most common type of lens with one single point of focus. So you will need glasses for other distances, but it's a very good lens that gives you very clear vision in the distance. So it's fantastic for driving, but you would need glasses for close work and intermediate vision. Then you have the extended depth of focus lenses, which are designed to give you good intermediate and far vision. So if you were mostly an outdoor type, it would be very, very good, and you didn't want that interested in reading, for example, or rarely read, this would be a good lens for you. Whereas the trifocal, it gives you the best of all worlds. It gives you a near point for you to read, small print, an intermediate for you to see your computer, and good distance far vision for driving. Now, what we need to talk about a little bit is about the potential side effects of the extended depth of focus and trifocal lenses, because the sharpest and clearest vision is always attained with the monofocal. But because a lot of these lenses use the diffractive principle of light, the brain has to get used to the lenses, and because of that you can sometimes get aberrations, and these aberrations are halos and glare. So some people won't like these lenses, and it's important to establish whether they would tolerate visual aberrations. I'll show you exactly what I mean in a moment. Can we go on to the next slide, please? So this is a monofocal view. So you can see in the distance the tall buildings, and you've got a clear view, but you can't see very well intermediate and distance. That's the monofocal view. So you would need glasses to see intermediate and near. Next slide. Astigmatism is when it's almost a bit of double in the eye that has the astigmatism. So you can sort of almost see that lines are slightly hazy at the edges and almost double. Whereas normal vision, slide to the right, you can see things a lot more sharply. And that's what astigmatism does to your distance vision if it wasn't corrected by glasses or contact lenses. Next slide. So this is just a schematic showing you what happens when, if you've got an astigmatic cornea and you didn't correct the astigmatism, you would end up getting a big blur patch of light transmitted on the retina, and that would give you this slightly sort of blurred edges. Next slide. So this is corrected with what's called a toric lens. So this is a lens that's orientated in your eye to correct your astigmatism by neutralizing it. And what we do is we implant these lenses in a particular axis according to the measurements that we get, depending on your degree of astigmatism. So once you would have some measurements done in the clinic, and then we would, at the time of cataract surgery, you would have the lens orientated in such a way to neutralize your corneal astigmatism and allow much better clarity of vision in the distance. That's how they work. Whereas extended depth of focus lenses are designed to give you good intermediate and distance vision, so they're very good for sporty types. And most activities can be fulfilled without needing to wear prescription glasses. However, if you wanted to see very fine print and near vision, you would need reading glasses. But it allows those people who are particularly active to have very good general vision without the need of glasses. Next slide. And the trifocal lens, and the one that we use at Springfield and at the Rivers, is the Zeiss Trilisa lens, and this has 3 distinct focal points. It's almost a bit like a varifocal, but not quite. It has 3 focal points, one for near, one for intermediate, and one for distance. And so it would allow a patient to be hopefully more spectacle independent. Next slide. Now, I did mention a little bit about side effects, and this is really important to discuss this with the patients at the beginning, because you can get this halo and glare effect. So if you look at the slide to the right, you can see little light halos of around headlamps. And this is particularly common at night. And so we don't recommend these multifocal lenses for night drivers and people who are lorry drivers, because they would inevitably get some degree of halo and glare. Why do you get it? Well, we think it's because of the diffractive principle of the physics of the lenses. They have rings of magnification. What people need to understand is it's not a light-to-light replacement. You're not replacing your natural lens with a lens that works in the same way. Your normal lens used to work by changing shape, and that would allow the rays of focus to alter, whereas the diffractive principle of physics is rings of magnification, and that means that there's a different physics-like principle here, and so you will get some degree of halo and glare. Now, most of the time the brain sorts it out, and the majority of people lose this halo and glare over a period of time as they adapt. But there are some people who are particularly looking for visual aberrations, and so it's important to establish who those patients are from the outset and try not to steer them away from these types of lenses, as they probably won't get on with them. Next slide. What about glaucoma sufferers with cataract? Well, cataract surgery alone can be a treatment for glaucoma. If you have a narrow drainage angle and you remove the physical presence of the lens, that will allow you to see, that may treat the glaucoma itself. But a lot of the time, if we just operated on the cataract alone in glaucoma sufferers, they will need to continue to take their medications. You could do laser trabeculoplasty, as Marina mentioned earlier, and that can deal with the elevated eye pressure separately. But we now have the opportunity to combine cataract with these MIGS devices. MIGS stands for microscopic, insertion of glaucoma devices. And so the Hydrus microstent is one such device. Next slide. What is the Hydrus microstent? Well, it's a small device that is flexible, made of niotol. Now, niotol is a material that has been used in stenting, particularly in cardiac stenting, for many years. And this is a very, very small device that is implanted in the drainage angle and has these little open windows which allow the drainage channel to be stented and also improve the drainage channel. Next slide. Its mechanism of action is thought to be threefold. It has a way of stenting and scaffolding, and also accessing the drainage angle to allow more fluid to drain through it. And these stents are implanted into the eye and work very well. Next slide, please. So my experience with the Hydrus implant, I've been putting them in for over 2 years now, is very positive. I tend to offer it to my patients if they have pre-existing glaucoma. Augmented with cataract surgery, it's a very easy procedure to do. The only thing that you need to warn people is sometimes when you insert the stent, there's a little bit of spot bleeding at the site, and this can cause a little bit of smoky vision for a few days. And so compared to cataract surgery, you may take a couple of days, 2 or 3 days, for the vision to clear before you have sharp vision following your cataract surgery because of the insertion of the stent. But the intraocular pressure is very, very good. The patient rehabilitation is fast and the patient satisfaction is very high. And when they've compared patients who have had cataract surgery alone and cataract surgery combined with the stent many years later, the effects are very, very similar. Next slide. So I've got some results to share with you of my own audit. At 12 months, I had 85% of my patients were on no medication. These are all patients who had glaucoma and cataract, who had the Hydrus stent at the time of cataract surgery. And my results compared very favourably with the Horizon study, which was 78% at 2 years. The complications are very low and transitory. We had hyphema, which is blood in the eye, and mild inflammation. One patient had an infection reactivation, and that was probably because of steroid use. One had fluid behind the eye, but that's a common complication about 5% of individuals. And we had quite very, very good reductions in pressure. 62.5% achieved a 20% reduction, 62.25% achieved a 30% reduction, and 12.5% a 40% reduction. And I put the study comparisons next door to that as well. So really, really good pressure reductions in our patients. Next slide, please. This is a slide of just to show you what it looks like when the stent goes in. So if you just press play, it shows a special cannula is inserted in the eye. We access the drainage angle using a special mirror, and as we inject it into the eye, you can see the stent sort of coming out, and when it comes out, you sort of see a little metal bit. Now, this one I thought was a little bit on the proud side. So if we go to the next slide, you go to the next slide, please. Yeah. So this one was quite prominent. So this is an example of sorry, the last one was okay. This one was a little bit more prominent. We inserted the stent, and then we thought that quite a little bit was hanging out. And it just goes to show how easily it is to just push it back in when you're not happy. So this one came out, and I thought, and I thought, oh, it's showing up as being quite prominent. But you can then put in a, if you go to the next slide, you can then put in the next slide, sorry, and this is, you can just put a little cannula in, and this is me just pushing it back into the drainage angle. So I've just used a little hook here just to feed it back in and just push it into the drainage angle, so that we're happy that it's a little bit of the metal tip is showing out. Normally about 50% of it is coming out at the end. You don't want too much of the end of the metal bit. That's about right as your end point is how much you want to show. So really, in conclusions, cataract surgery with the use of the Hydrus microstent provides excellent visual acuity without the need of medications in moderate glaucoma sufferers. We can provide this at Springfield Hospital. It does have a code, so it's covered by insurers as well, and there is a total care package included for those self-pay patients if they want to have the Hydrus microstent in addition to the cataract surgery. Next slide.
You finished now?
That's it, right, okay. I apologise for my camera problem on my big PC, but we found another device, so hopefully you'll enjoy the talk, and very happy to answer any questions.
Yeah, thanks, Mr. Andreou. We do have a question. So someone has asked, they've heard about YAG laser being needed after cataract surgery sometimes. If you have a trifocal lens, does this still help with avoiding YAG laser?
No, because the risk of developing capsular fibrosis depends on the quality of the lens that you put into the eye. Now, that's a very good question, because what we found is that our friends Spa Medica up the road, who do very, very large volumes of NHS surgery, they use a single plate lens for all their cataract patients. And the reason they use this lens is because it's relatively cheap on the market, but it has a very high incidence of capsular fibrosis. So we're seeing a lot of people needing laser treatment, up as many as 50% after cataract surgery. And this is because what you want is a barrier to stop these cells from growing on the back surface of the lens after you've done cataract surgery. And it's the type of implant designed, whether it has a square edge or it fuses with a capsule, that allows this not to develop. So the lenses that we use at Springfield tend to have a much, much lower chance of developing capsular fibrosis, because these are better quality lenses. They're made of hydrophobic and hydrophilic material, and also they have square edges which prevent this from happening. So it doesn't matter about whether it's a monofocal or trifocal or a toric lens. It's more about the design of the lens and whether it's a barrier to preventing capsular fibrosis from occurring. So I would say that anyone who uses a single plate lens, has a much more high chance of that developing. But it depends on the actual, whether the edge of the lens has a square edge or fuses with the capsule.
Okay, lovely. Did anyone else have any questions that they wanted to type? Can cataracts cause headaches?
Only if they cause a big imbalance between the two eyes. So, for example, if a cataract caused a refractive change, so if it made someone, for example, very short-sighted in one eye and they became unbalanced, then you could get symptoms of tired eyes and headaches from that, because there's a big imbalance between the two eyes. One of the things, if someone has a very large refractive area, and when we say refractive area, we mean someone who's very short or long-sighted. If you do one eye and you set it for distance, the other eye is still very short or very long, and there can be imbalance with headache, in that situation. So what we tend to do is do the second eye very quickly afterwards to limit that problem. Whether you can get the second eye quickly within an NHS setting is debatable, but ideally they should be offering patients who have very high refractive areas the two eyes quite close together to stop this sort of thing from occurring.
Okay. Another question, how long does the surgery take and what is the recovery time?
So if it's cataract surgery alone, you would expect to have blurred vision that day. From the next day onwards, your vision improves. So you might be fortunate and have crystal clear, sharp vision from the next day, or it may take a few days for the vision to clear. In terms of the eye healing, the typical effects that people get are grittiness of the eye, a redness, watering, and light sensitivity. Everyone will get a certain degree of that. That's normal. That's a normal healing response, and everyone varies. But most of the time, it's not a big problem, and we give eye drops which help with that. So the rehabilitation times are very, very quick. What we don't want people to do is go and exercise very heavily or swimming and do things like that. So we warn people not to heavily exercise within the first month or swim. But certainly general sort of walking around, light walks, you know, doing light tasks is absolutely fine very early on.
Lovely, thank you.
I just wanted to add about cataract that, you know, pressure, sometimes eye pressure can go up if you have bad cataracts. And I think it's worthwhile to see an optician to check your glasses and to check your pressure, because headache can be caused by pressure in the eye.
Yeah. Yeah, there's a rare type of glaucoma where you get a very mature white cataract, and it can cause pressure in the eye. And also, if you're very, very long-sighted, so your prescription has a high plus numbers, if you develop a cataract, that can cause the pressure to go up as well, because the physical space in the eye is quite small, and as the cataract develops, it closes the drainage angle and can cause the pressure to go up. So rarely cataract can cause pressure in the eye, but it tends to be much rarer if you look at all the scheme of things. However, Marina's right, it is a cause. And so what we always say to people, if you're developing a blurring of vision, go to your optician first, and most opticians will check their eye pressures and as part of their normal exam.
Okay, lovely. Another question: if you're squeamish, can you have general anaesthetic, or are you only offered a local anaesthetic?
Absolutely. Particularly in private practice, we offer people, we give people options of local anaesthesia, sedation, or general. I have an anaesthetist that I work with on a monthly basis, and in those patients who are anxious, we can offer them sedation. That involves often what I call injecting them with happy juice to make them feel very, very calm. So you're light, you're not completely not aware of things. You're light, but you're still aware of things. What you might do is forget what happens, but they use a very, very light sedation. Or general anaesthesia for those patients who completely, you know, don't like anyone touching their eye. So you can have it done any way you like. The majority of cataracts are still done under local anaesthesia, even numbing drops. So most people can have their surgery, you know, just with numbing drops, or with a cannula inserting a little bit of anaesthetic around the eyeball, and that's a safe way to do things as well. Because the surgery generally is quite quick. In most hands, it's fairly quick, and has a very, very low complication rate. So most patients do very, very well with local anaesthesia. Okay,
lovely. I think that might be it for questions. If anyone else has any more, they can drop them down into the chat quickly. But if not, we can otherwise leave it there and say a big thank you to Mr. Andreu and Miss Hopes for presenting. And thank you everyone else for attending.
Pleasure.
Thank you very much, guys.
Okay, bye.
We'll leave it there. Thank you. Bye-bye.
Bye.
Hi, I have recently had a second dose of SLT as a first treatment didn't work. What are my options if the second dose isn't effective? Actually, there was a big study done called Light Study, and they showed that SLT can work even better second or third time. And there is no limit how many times you can do SLT. So I wouldn't worry. I think you just have to give a good chance for SLT. If because the blockage can be at any level. SLT can only open, so it's, you know, in a sink, when you're looking at the top of the pipe, it's what SLT can unblock. But we have no access to the deeper tissue with SLT. It's where this mix come to force, like Hydrus, Omni or Minijet, and there are other options available to try, but SLT is just really nice treatment if it works, and I think it's worthwhile to try, because we usually offer SLT if you have time to try different options before you give up completely. I hope it will answer your question, and I'm sure Petrus would like to say something, but I'm just trying to help and answer on his behalf. It was a question to all of us. So there is another question. Sorry, not a glaucoma question, but I have recently been told I have early lens change. Is there anything I could do to prevent this getting worse? In the real world, honestly, you can't. Unless you have steroids or you have chemical treatment, chemotherapy for cancer, and the main risk for cataract development is age. And there are no drops which are truly can slow down single diet. You can be sold something, but we know as a doctors that there are no evidence to support these claims. So I would be very careful, and it's just something which we hope that it just will develop very slowly.